know a good number of people already joined and online, and people who are busy, they can always reach out and listen to our recorded session. So, Assalamu alaikum, welcome everyone. Bismillah ar-Rahman ar-Rahim. It is my pleasure to introduce Dr. Nida Anwar. She's a professor and a consultant hematologist at the National Institute of Blood Disease and Bone Marrow Transplantation in Karachi, Pakistan. And she's talking about a topic which is very important in the malignant hematology space. She will be discussing management of low and high risk myelodysplastic syndrome. So I will invite Dr. Nida to take over and start her presentation. Thank you.
Thank you, Dr. Anwar. It's a pleasure for me, and thank you for this humble introduction. Today, I'll be talking about management of low and high risk myelodysplastic syndromes. Myelodysplastic syndromes, now termed as myelodysplastic neoplasms, are a heterogeneous group of clonal hematopoietic stem cell disorders, which are characterized by peripheral blood cytopenias and related complications, morphological evidence of dysplasia, evidence of clonality by cytogenetic or somatic gene mutation, and an inherent tendency to evolve into acute myeloid leukemia. The diagnosis of MDS is generally suspected based on the presence of blood cytopenias, and the diagnostic test used for the confirmation of MDS include careful evaluation of the blood film to see the morphological dysplasia, bone marrow examination including the aspirate and trophine to see morphological dysplasia, presence of blast cells, ring sideroblast, degree of fibrosis, presence of immature cells, and cytogenetics ruling out the karyotypic abnormalities. The additional assays for the diagnosis of MDS include flow cytometry, fluorescent in situ hybridization, genomic sequencing techniques, keeping in view the conventional karyotyping, the chromosomal patterns have quite instability. They're not stable and can change as the disease evolves. And these, in turn, new cytogenetic changes are linked to higher risk of transformation into acute myeloid leukemia and poor survival rates. Therefore, the new techniques, including the optical genomic mapping, they are the new methods for detecting large chromosomal changes without the need for the cell culture. And their advantages are reduced number of errors and producing more reliable test results. However, they are not employed in the routine and still in the research. There are various risk factors for MDS, including prior chemo or radiotherapy, multiple genomic events, inflammatory and innate immunity dysregulation, and dysregulated apoptosis. Coming to the risk stratification of the myelodysplastic syndromes involve the conventional risk models like IPSS and IPSS-R, which incorporate the peripheral blood cytopenias, percentage of the blood cells, cytogenetics, with IPSS-R involving more depth of the cytopenias and more refined cytogenetic categories, thus characterizing myelodysplastic syndromes into very low, low, intermediate, high, and very high, as compared to IPSS-R, which stratified MDS into low, intermediate 1, intermediate 2, and high. But now the world is moving to a newer risk models, which is termed as IPSS-M, and that incorporates the genetic mutation in addition to the cytopenias, blast cells, and cytogenetics to provide more refined risk stratification of the disease and treatment plan. Coming to the prognostic value of the cytogenetic pattern in MDS, as we discussed, the very good cytogenetics involve the -Y and deletion 11q, the good involving deletion 5q, 20q, 12p, and normal karyotype, the intermediate ones involving trisomies like trisomy 8, 19, 21, deletion of long arm of chromosome 7, and the poor ones which involve the monosomy 7, complex cytogenetic abnormalities up to 3, however, the very poor involved complex abnormalities more than 3. This in turn determined the median overall survival and transformation time into acute myeloid leukemia. The current 2020 WHO classification of MDS stratifies MDS into MDS 5Q, that is MDS with low blast and isolated 5Q deletion, which includes less than 5% bone marrow and less than 2% peripheral blood blast. MDS SF3B1, which is basically MDS with low blast and SF3B1 mutation, having less than 5% bone marrow and less than 2% peripheral blood blast. MDS with biallelic TP53 inactivation, carrying less than 20% bone marrow and peripheral blood blast. However, the MDS morphologically defined is somewhat similar to the conventional categorization that we had previously. That is MDS with low blast, hypoplastic MDS, MDS with increased blast, that is MDS IB1, having 5 to 9% bone marrow blast or 2 to 4% peripheral blood blast, MDS IB2 involving 10 to 19% bone marrow or 2 to 19% peripheral blood blast, and another one is MTS with myelofibrosis involving 5 to 19% bone marrow or 2 to 19% peripheral blood blast. About 20% of the patients with MDS are misdiagnosed. So this is very, very important to identify the early stage, to identify MDS at an early stage and rule out the clonal conditions. And there's the newer concept of ICUS, CICUS, and CHIP. In general, all three categories, that is ICUS, CICUS, and CHIP, do not have any robust morphological evidence of dysplasia, thus not qualifying them to MDS per se. However, when we talk about ICUS, ICUS is basically the idiopathic cytopenias of undetermined significance. In ICUS, the patients have cytopenias, but there's no evidence of any somatic mutation. Therefore, the risk of progression of the disease is very, very low. In case of the CICUS, CICUS is basically clonal cytopenias of undetermined significance. In CICUS, we've got the cytopenias and somatic mutation, however, there's no or minimal dysplasia. A CHIP is clonal hematopoiesis of indeterminate potential, where you've got no cytopenias, but yes, there are somatic mutation at a variant allele frequency of equal to more than 2%. And the most common somatic mutations identified are DNMT3A, TET2, ASXL1, and the risk of progression of the disease is very, very low. So currently in the developed worlds, there are nowadays CHIP clinics where the patients of CICUS and CHIP are being followed at, because the newer concept is that evidence is suggesting that there's a correlation between the cardiovascular problems and CICUS and CHIP. So this requires monitoring. Coming to the mutation in MDS, there are founder and secondary mutation, which leads to MDS. And when we talk about the founder mutations, these mutations involve the splicing machinery, such as SF3B1 and SRSF2. The mutations which involve the DNA methylation, including DNMT3, TAT2, IDH1 and 2. The mutations which involve the chromatin modifications, which include the ASXL1, EZH2. And then comes, after the founder mutations, come the secondary mutations, which involve the transcription factors like TP53, RUNX1, the mutations involving the signal transduction involving the CBL, RAS, and JAK, and then the mutations involving the cohesion complex like STAT2 mutations. So this is a slide demonstrating the reported frequency of these genetic lesions in MDS and order of frequency, most common being SF3B1, TET2, ASXL1, SRSF2, RUNX1, TP53, and so on. So when we talk about the treatment in MDS, there are various important considerations before you embark on the treatment. First of all, it's very important to determine the risk of the disease. Is the patient low risk or high risk MDS? And is the patient having symptomatic cytopenias, and how symptomatic is the patient? Is the cytopenia a single cytopenia or multi-lineage one? Then if the patient is transfusion dependent or the patient is not transfusion dependent, what are the comorbs of the patient, the performance status, and all the patient-related factors, the mutational profile, as a lot of high-risk mutations change the prognosis and treatment outcome. Is the patient potentially a candidate for allogeneic transplant or not? And is the patient has got a prior HMA failure or not? So these are the various important considerations to see before you embark on the treatment. So in general, the management of MDS thus focus on slowing the disease progression, managing the symptoms, preventing the complications, and treating based on the risk level of the disease and keeping in view carefully the individual patient risk factors. So the goals of treatment are different in low and high risk. In low risk disease, the main goal of treatment is to decrease the transfusion need and transformation to the high risk disease, that is AML. And in the high risk, the main aim or goal of the treatment is to prolong the overall survival. And in general, the main aim of the treatment is to improve the health-related quality of life and overall survival of the patient. The various studies have shown that IPSS-M, in contrast to the IPSS-R, has a greater survival predictive accuracy, specifically in patients who are more than 60 years, as in subjects who are more than 60 years, there are high incidence of certain bad risk mutations like RUNX1, TP53, TAT2, SRSF, DNMT3. So incorporation of IPSS-M, that is the molecular profile, is at times very important to determine the prognosis and long-term survival, especially in patients who are more than 60 years of age. So as I mentioned before embarking on the treatment, risk stratification is very, very important. So when we talk about the low risk, by low risk means the patients who on the IPSS are either low intermediate 1 or by virtue of IPSS-R who are very low, lower intermediate risk. So the first important question is the patient having symptomatic cytopenia? Is the patient transfusion dependent? If not, just observe. If the patient is having symptomatic cytopenia or transfusion dependency, you need to determine what is the cytopenia. Is the patient having isolated anemia, thrombocytopenia, neutropenia, its manifestation, or it's a merge of combined symptoms? So if the patient has got symptomatic isolated anemia, it's very important to determine the baseline endogenous EPO, that is erythropoietin levels, and to check the patient for deletion 5q. So if the patient is negative for deletion 5q, isolated anemia, and if the erythropoietin levels are less than 500, it is that chunk of the patient which responds really well to the erythropoietin stimulating agents, plus minus GCSF. So the general strategy is to commence the patient on recombinant erythropoietin levels and observe the patient for the next 6 to 8 weeks. If the patient doesn't respond, you increase the dose of recombinant erythropoietin, and if that even patient is not responding, you can add the GCSF. This is basically the British policy, how you deal in. However, if the patient has got a baseline erythropoietin level more than 500, you still give them erythropoietin recombinant. However, this chunk of the patient responds less favorable as compared to those who have baseline erythropoietin levels less than 500. When it comes to the immune suppression therapy, it's a lot of controversial and ambiguous area, but in conventionally usually don't give immune suppression therapy generally in MDS. However, there are some favorable features like trisomy 8 or hypoplastic MDS, that is chunk of the patient who can respond to the immune suppression therapy like ATG or cyclosporin. But again, the careful consideration of the age, risk factors, risk of infection, comorbs, and everything has to be carefully evaluated. If the patient is having anemia and deletion 5q is positive, then the options that we have is lenalidomide or plus minus erythropoietin levels. And if you can see that you can give a trial of 8 to 8 weeks, and if there's no response or loss of response, you can institute patient on hypomethylating agents. When it comes to the isolated thrombocytopenia and the patient is symptomatic, so the options are thrombopoietin analogs, that is L-thrombopag and romiplastin. And if the patient doesn't respond, then there's an option of hypomethylating agents. If the patient is having isolated neutropenia, that is per se not an indication for treatment, however, if the patient is having symptomatic neutropenia, that is a history of recurrent infections, then that is the chunk of the patient who are to be given GCSF and hypomethylating agents. In addition, in the low risk, there's a category in which we have ring sideroblasts, and that is that chunk of the patient that responds is basically to the combination of erythropoietin stimulating agents and along with GCSF. Moreover, there's evidence of an agent which is called luspatercept after the Medalist trial, and that is also an agent that is to be given. The newer agents like mtelstat, they are telomerase inhibitors. They're also in the pipeline and are given treatment option low risk MDS. When we talk about the high-risk patients, these are those patients which on IPSS are either intermediate to and high risk, and by virtue of IPSS are intermediate, high, or very high-risk patients. So in case of high-risk MDS, it is very, very important to early identify the eligibility of those patients for the transplant, because the high-risk disease population of the patient are those who have to be considered for the stem cell transplant, and early institution of the transfusion team is very, very important. So if the patient is eligible for the transplant, just do the donor availability search, and meanwhile start the patient on hypomethylators to increase the disease burden and burden of the blast. And then as soon as donor is available, you can proceed for the stem cell transplant, ideally when the blast count is less than 10%. And if the patient is not a candidate for the stem cell transplant, then there's an option of hypomethylating agent per se, and minimum 6 months of response is noted before we can modulate the treatment plan. In hypomethylating agents, we have 3 agents, that is azacitidine, decitabine, and oral azacitidine sidazurine. In additional, the targeted mutation is very, very important. If the patient has got any targeted mutation, so now we've got the targeted mutated agents like ivosidenib and enasidenib, they can be given. And then we've got the options of clinical trials. It's always important to offer the patient clinical trial, whether it be high risk or low risk, wherever it's available. And then we've got the newer agents like guacitabine, rigosertib, and venetoclax. However, it's just a recommendation. However, in our part of the world, I belong to Pakistan and practice there. So there's a lack of the clinical trial, and that is the main gap that we face while practicing and treating patients with MDS. So as I mentioned, this is a slide taken from British Journal of Hematology, and according to just the difference is that in general, more or less, the treatment options are same for the low risk MDS. However, according to the British practice, in case of deletion 5q, the British practice is to give initially the trial of erythropoietin plus minus GCSF, and if the patient fails or relapse, then the practice is to give the lenalidomide. As contrary to the US practice, we can give straightforward lenalidomide. So the studies have also convinced that the erythropoietin and GCSF treatment is associated with improved survival. It doesn't modulate the disease per se, and it has no effect on the halting of progression of the disease to the high risk. However, it improves the patient transfusion dependency, and in turn improves the health-related quality of life, and in turn improves the overall survival. So, as we've discussed, the therapeutic options in high-risk MDS, as per the British practice, it's very important to assess the frailty of the patient, because usually in Western world, MDS median age at diagnosis is more than 65 years or 70 years. So it's very important to assess the patient-related factors, and if to see the patient is frail. If the patient is frail, then manage the patient with just supportive care, best supportive care, tender love, and just prophylactic antimicrobials. However, if the patient is less than 65 to 70 years, or sometimes even older, and it's not just an age formula, because the biological age is more important as compared to the chronological age. So if the patient is less than 65 and has a suitable donor, then proceed for the allogenic stem cell transplant. And if the blast is less than 10%, straightforwardly proceed for the transplant. And if the blasts are more than 10%, then reduce the disease burden either by chemotherapy or hypomethylating agents. And if the patient is more than 65 or 70 years, there's no eligible donor, then give AML chemotherapy or azacitidine, and try the patient with at least 6 cycles, and in case of relapse, once again, consider the patient for clinical trials of the newer agents. So as we've just discussed, that allogeneic stem cell transplant is potentially the only curative treatment in MDS. Therefore, all MDS patients should be considered for allogeneic stem cell transplant. The patient of high risk should be referred at diagnosis earliest as possible in the disease course. And for those with low risk, the referral may be less urgent. However, they should be closely observed and quickly referred whenever appropriate. Then comes the patient-specific consideration and factors, as we've just mentioned, that it shouldn't be limited by just the age per se. There are more factors like comorbidities, performance status, the biological status of the patient, the severity of comorbs, because sometimes the severity of the comorbs may significantly influence the transplant success as well. So there has to be a really, really careful and individualized approach and consideration. When it comes to the disease, the high-risk MDS and therapy-related MDS with prior history of chemo radiotherapy or were transformed, for those chunk of patient, allogeneic transplant should be considered because they usually have very bad outcome. And once again, another important aspect is when you are considering the potential related donors, germline mutations should be sought and considered. And this is especially pertinent in our part of the world because we don't have, in Pakistan, we don't have a robust any donor registry. So we have family donors, and the potential donors are either the brothers or sisters or parents. So germline mutation should be screened. Then the disease-directed therapy and transfusion overload, because by the time the patient is proceeded for the transplant, there are a lot of transfusions. So serum ferritin level and aggressive iron chelation is very, very important. And it does impact the transplant outcome because high ferritin level before the transplant is associated with post-transplant complications. When we talk about the conditioning regime, both reduced intensity conditioning or myeloablative conditioning regimes are acceptable for the allogeneic stem cell transplant in MDS. However, RIC is associated with less toxicity, and MAC is associated with more graft versus leukemia effect. So again, it has to be an individualized approach and institutional practice. However, MAC may be preferred in fit young patients who are low risk because it is associated with lower post-transplant relapse risk. And when, especially in the Western world, there's an option of alternative donors. For instance, if HLA matched donor is not available, then there's an option of haploidentical relatives or match and related donor transplant or umbilical cord transplant could be considered as an alternative option. And as far as the post-transplant maintenance is concerned, currently there's no standard recommendation of maintenance therapy in MDS after stem cell transplant. There are certain studies and observational studies which have shown inclusion of like hypomethylators like azacitidine post-transplant and shown the effect. However, there's no per se standard recommendation to give maintenance post-transplant in MDS. Now I would be a little bit talking about the situation in Pakistan that we encounter while practicing. So in Pakistan, when we treat MDS, there are a lot of challenges and gaps that we encounter. The first challenge that we encounter is the funding, because unlike West, health is not funded in Pakistan per se. There could be variables. Sometimes the Sindh government, sometimes the Punjab government variably give a certain amount of funds, but they're very variable. So the first important challenge that we encounter is funding for treatment, funding for clinical trials, funding for the research. And secondly, cost. The treatment modalities may be, the transplant or the pre-transplant care, or it could be hypomethylators. They are costly treatments. It's very difficult for the patient to afford those treatments from their pocket. And then another concept that I wanted to highlight, which I encounter and we encounter in our practice, is most of the patients, there's difference of IQ, social background, education status, and patients believe that blood transfusion per se is a better option. And sometimes practically it's very, very important to counsel the patient that blood transfusion is a recombinant erythropoietin is better than blood transfusion. And then there's a dilemma of doses of erythropoietin, because a lot of the patients and even the practicing physicians believe that the standard doses of erythropoietin, say for example 30,000, 40,000 70,000, 80,000 international units, which is the standard dose in the Western world, is a very, very high dose. And it's very difficult to accept the high dose, and it's very difficult to keep on affording it, because there's a patience, you need to wait for the response. Contrary, when you give blood transfusion, there's a symptomatic improvement the very next day. So this gives a false reassuring feeling to the patient, and sometimes very difficult to counsel the patient. And then is the duration of the hypomethylators. When we counsel the patient that we have to give at least 6 cycles and then so on. So again, it's very difficult to convince the patient that if even if you're responding, then we have to continue the hypomethylators until the unacceptable toxicity or the loss of response. As far as the transplant is concerned, Pakistan is doing a lot in terms of the transplant. We've got a lot of progress in transplant, especially in thalassemia or aplastic anemia. However, we're still struggling for the transplants in case of MDS, because there are very, very limited numbers of the transplants so far done in Pakistan in MDS. And the reason could be the cost. And usually in old age, there's a concept that once the patient is 50 years, 60 years, 40 years, they've lived their life and they're not willing to pay. The family is not willing to pay. The children are not willing to invest for the transplant. And then again, the performance status, because the nutritional value, the general performance status, especially when we encounter the females who come with MDS after the transfusion dependence, infections, their performance status is very, very variable. So in general, it's also difficult for us to really think that are these patients potentially a candidate for the transplant or not. So I spoke about all the problems and challenges. Now, the strategic pathway that we already and PBMT is working on is we are collaborating and trying to collect the multi-center data. And PBMT is kind enough to give me opportunity to lead, and I'm working on the national registry, the multi-center data, and we are working our best to incorporate the national guidelines and patient awareness and education. Last year, we had a very good session for the MDS, and this is what we are trying to do to improve the practices of MDS in Pakistan. This is some of the data, Pakistani data. There are two data that I would like to discuss. This study is from NIBD. It was published back in 2017, and in contrary to the West, the observation that we found is MDS is found at younger median age as compared to the West. So our median age was 51 years, which is less as compared to the West. And surprisingly, we usually don't have significant history of recurrent infections. Patients usually present with symptomatic anemia and transfusion dependence of the red cell. We don't frequently encounter the history of recurrent infections or recurrent the thrombocytopenia and presentation. Coming to the cytogenetics, complex karyotype and monosomy 7 is frequently encountered. However, as far as the molecular data is concerned, we don't have any robust molecular data. Another big cohort study has been done in AFBMTC, and similarly, they also observed the same observations that we have male predominance. That is obviously similar to the West. However, they also found the younger median age was 58 years, and the most common presentation, as I mentioned, is anemia, and the most common category that we encounter in MDS is RCMD. And the most common cytogenetic abnormalities are complex karyotype and trisomy 8 and deletion 5. So this was back in 2021 when Dr. Tahir Shamsi was there, and he was very enthusiastic, and he tried his best to start the next generation sequencing in MDS, and we were we did NGS of 22 patients. However, we had lack of funding and we were struggling to get this done. So it's a very limited data, but we tried to start this. And currently, AFBMTC has recently started the NGS there. So we're trying our best to incorporate more of the molecular data and have a more robust Pakistani data. Another interesting observation is when we did a case control study pertinent to the environmental and occupational risk factors, because in even if we've seen the MDS in a very younger age, like 25 years, MDS with proven cytogenetic and clonal abnormalities. So we're quite concerned that what is the reason that we're getting MDS in such a younger age. So one of the interesting observation were that the people who belong to the rural area, the less educated ones, and especially those patients who come from a rural area who are very in routine, they take the raw water, especially the Thar area. They had more prevalent of MDS, and then we encountered that that water had arsenic. So there could be various factors, maybe the environmental factors or any certain other factors that could be related to the early onset of MDS in our part of the world. So then the research blood count parameters, we're trying our best to incorporate the newer research parameters, as NGS is not possible every time. However, it's not the replacement. Still, the peripheral blood morphology, cytogenetics, and molecular mutation have to be there. However, this is just, we are trying to establish local data. Coming about the recent developments, so we spoke about the standard recommendations, and then the world is moving more towards the recent developments and therapies like targeting anti-apoptotic protein, that is venetoclax as a combo, where a trial is going on, and then the therapies which include the NADA dealylation inhibitors, that is nadisat combo with azacitidine, signal transduction inhibitors like ligosertib and KRAS inhibitors alone in combination, and then isocitrate dehydrogenase inhibitors, inflammatory pathway inhibitors, and immune checkpoint inhibitors. So this is the recent development that is going on and targeting various, as I mentioned, anti-apoptotic proteins, NADA inhibitors, signal transduction, isocitrate dehydrogenase inhibitors, inflammatory pathway inhibitors, and checkpoint inhibitors. They've shown the variable response rate and somewhat improve overall survival. So, and then the future direction, artificial intelligence, which is the future in MDS. However, I would just like to summarize that the newer future directions, artificial intelligence, but the mainstay of the diagnosis is still the blood film morphology, the blood film careful evaluation of the bone marrow, cytogenetics, and incorporation. Now the world is moving towards the molecular insights. So with this, I would like to thank you all for your patience, and I'll be happy to answer if there are any questions and queries. Thank you.
If anyone have question, you can raise your hand. We can allow to speak.
Yes,
Good
please.
morning. Can you hear
Good
me?
morning. Yeah, I can
Yes,
hear you.
Dr. Nida, thank you very much for your wonderful lecture. I enjoyed indeed, although the slides were a little bit congested, but a lot of. One quick question about the prevalence of uh, plasma cell tumor in Pakistan. What is the like multiple myeloma I'm referring to?
Mhm. Well, the exact prevalence, I won't be able to comment because we have a lack of like national data, but it's common as compared to MDS. We usually encounter plasma cell uh, myeloma more as compared to MDS. Yeah.
Okay, thank you. Sounds good.
Yes, please.
Hello, very nice lecture. And I want to confirm which hospital provide bone marrow transplant in Karachi.
In Karachi, there are two big centers. One is NIBD and one is Aga Khan University Hospital.
So thank you so much.
Yes, please.
Dr. Nida, please answer the questions in QA box.
In Pakistan, do you have the stem cell bank facility?
Not the stem cell bank facility. We don't have that in Pakistan. Yeah.
Stem cell donation is not available in Pakistan.
The stem cell bank and preservation facility is not there.
I see. Okay, thank you.
Yeah.
Dr. Nida, some participants put their answer in QA box. Please answer them.
I'm sorry, I'm not able to figure out. I'm just trying to see. Really sorry, but I'm struggling to find questions I can see here.
QA box, Q&A at the right bottom of share, where you put share screen. Or I think
If you would be kind enough to read those questions, I'll be happy to answer. I'm sorry, I'm not able to find those questions.
first one, how to treat a 70-year-old male patient with PS0 MDIB1 cytogenetic 45XY del 5Q minus 13.
All right. So basically, what I got is the patient has got low IPS. He's 70 years. He's got isolated deletion 5q and a single abnormality. So basically, it's very important to evaluate the patient, as I mentioned, biological age, because chronologically, in our part of the world, I'm talking about Pakistan, a 70 years male has a very different performance status as compared to the West. In the West, in the UK, USA, the patients who present with 70 years age have very, very good performance status. So first of all, and how symptomatic the patient is for the transfusion. If the patient is transfusion dependent, give the transfusion to improve health-related quality of life, and there's deletion 5q. Give the patient trial of erythropoietin. You can also institute lenalidomide. Depending upon the dose and tolerability, the usual conventional doses in MDS is 10 milligrams daily for 21 days. But depending upon the cytopenias and toxicity, you can always modulate the dose. You can even give the dose as 5 milligrams daily to improve the health-related quality of life. And usually the low-risk patient and 70 years patient, I don't think such a patient would qualify for the transplant. So just improve the quality of life, give a trial of erythropoietin, lenalidomide, and symptomatic transfusion.
Thank you, Dr. Nita. Next question, what is your current experience regarding the dosage and duration of ISA plus when treatment in MDS?
Well, ESA and when azacitidine is approved in MDS, and the conventional dose is 75 milligram per meter square for 7 days, every 28 days. When it comes to the venetoclax is not approved per se in MDS. However, practically in an IBD, we do give venetoclax, as there's a very good robust evidence of Verona trial. But again, it depends. We usually don't give 28 days, and not as the case in MDS, because Verona trial also incorporates the 14 days. So it's always like we modulate the dose. And we start usually with the lower doses, and we get an edge because whenever we give the antifungals like voriconazole, the usual dose that we give is 100 milligram. So we start with 7 days, and then we can go up to like 10 days. Or I don't think hardly we've given any patient 14 days treatment. So usually what we give is 7 days azacitidine with 7 days of venetoclax, or we also give decitabine, because in our part of the world, the cost of decitabine is less as compared to azacitidine. One cycle of azacitidine is equivalent to the 2 cycles of decitabine. So we sometimes prefer decitabine depending upon the cost as well.
Thank you. Third one is by allelic TP53 mutation treatment of choice.
TP53 biallelic mutated has a very, very bad prognosis. If you see at the Western data as well, even if the transplant, the outcomes are very bad. So you proceed for the transplant. Obviously, it's a high-risk mutations. You would tend to go for the transplant, but counseling of the patient is very important, that the outcome is poor, and there are very, very high chances of relapse. Yes? I can see some raised hands. Yeah.
Yeah, Dr. Nida, thank you so very much. I just want to ask, what is the prognosis of MDS in Pakistan versus UK population? And lastly, if there is any difference, so what's the reason in the difference of the prognosis? Thank you so very much.
Thank you for this question. I would just say that there's a lot of difference, because in our part of the world, in Pakistan, as I mentioned, performance status is different. Here in the Western world, people are more fit, maybe the males or maybe the females. In Pakistan, the performance status is not that. The diet is not that appropriate, especially for the females, and there's lack of awareness. The referral system is very different as compared to the West. Most of the patients, most of the physicians even don't timely refer the patients for the diagnostic like marrow and cytogenetics and everything. So, and there's a perceived belief that blood transfusion is better as compared to the standard modalities of treatment, and then availability of the transplant. In the Western world, transplant is a very feasible option, especially for the high-risk MDS. In Pakistan, we have limited number of the transplant, and then again, as I mentioned, the treatment cost, the treatment dilemma, that the concept that you have to take on the medication and there's no fixed duration, may be the lowest treatment options or high risk options. So that makes the treatment, and sometimes there's a loss of a patient become lost to follow-up. They start the treatment, and when they become transfusion independent, they just lost to follow-up. So I mean, I would just summarize that there's not one difference, there are a lot of differences, but we're just trying our best to make more awareness, and we're trying to collaborate with the people, the stakeholders, for more funding and more robust systems for the sustained treatment of the patients in Pakistan.
Thank you so very much, Dr. Nida. Thanks a lot.
Thank you. Yes, please.
Dr. Glasnover, you can ask your question.
Yes, Dr. Aziz. I can see raise hand of Dr. Abdul Aziz. Yes, please. Dr. Aziz, I can't hear you.
If no one have any question, I think we can conclude the session. If anyone have question, they can put their question in WhatsApp group or email. Thank you, Dr. Nida.
Thank you. Thank you very much.